Well, thank you so much for joining us. We are waiting 1 minute while everybody is joining the webinar. Want to thank you all for being on this morning.
Good morning.
Good morning. And we are going to mute all lines to start. And if you do have a question during the webinar, please just use your chat button, which is at the bottom of your screen, and we'll be taking questions at the end of the webinar. So let's go ahead and get started. My name is Kristen Strom. I'm President and CEO of Common Sense Policy Roundtable. Common Sense Policy Roundtable is a 501c3 nonpartisan nonprofit organization. We're a research institute and look at critical public policy issues facing the state of Colorado. In just the last year, we've provided Coloradans with facts and economic impacts on tax measures, paid family leave, Initiative 300, which was a Denver homelessness issue, and oil and gas setback measures, just to name a few. We've also spent a lot of time the last year looking at what is called the Colorado Public Option. We're supported by a board of 13 members and wonderful community partner and organizations. Since the COVID crisis, this is our third webinar that we've hosted, and we hope that you find it useful today. So let's get started on our topic. What exactly is the Colorado Option Plan? Most of you on this call looks like you might be familiar with it, but I do see some new faces joining us today. So I'm going to give a brief overview. In 2019, HB 19-1004 was passed by the Colorado legislature and signed by Governor Polis. It started a state exploration into a so-called public option government-run healthcare plan. You flash forward to this session, and the legislature began crafting Colorado Option Plan House Bill 2013-49. It's now called the Colorado Option Plan. It's a significant expansion of the role of government in healthcare, the first of its kind in the nation, and the plan is based around government set prices and required participation by hospitals and insurance carriers. In light of the current crisis, the legislature temporarily adjourned in March. They're set to gavel back in May 18th, and it was widely thought that proponents might bring this bill up again. However, on Monday, we had some breaking news that the sponsors of the Colorado Option Plan would be pausing moving forward with this piece of legislation. They should be applauded for halting moving forward, especially when our healthcare system has been on the front lines fighting the current pandemic. But their stated intention is to pass the bill either later this year if there's a special session or bring it back up in the 2021 session. So that makes today's discussion even more important. Coloradans and policymakers still have a lot of unanswered questions around the so-called public option. And today, what we want to do is shed a little bit of light and start the conversation around what some of the potential economic impacts related to this potential disruption in our healthcare system might be. So we're going to kick off the program, starting with our Director of Policy and Research, Chris Brown. Chris?
Great. Thank you so much, Kristen. And thank you all for joining us today. I wanted to just do a brief refresher for those joining on the timeline and the sequence of events that have occurred in this particular debate. This is an issue which CSPR has been engaged in from a research standpoint since last fall. This issue really took off at the end of last legislative session. There was a series of stakeholder meetings last summer that were to culminate in a final report from the state last November. We released our first research into this topic prior to that last September. We released a second paper in January of this year following the final recommendations. And as we saw the introduction of House Bill 2013-49 this session, decided to update the analysis and ultimately released the report, which we finally released this morning, and are sharing the results with you today. And I would just like to thank and acknowledge, we have one of our key consultants that worked with us on this work today, but I'd like to acknowledge and thank Rick Rush, who was a co-author on our second report and also contributed his insights and to this third paper. So to this point, the research that has been generated from the state and the state's actuary, Wakely, has focused on a couple key elements of the policy debate. Specifically, how would the state establish the public option, or as it's now termed, the colored option plan, reimbursement rates for providers or now hospitals? How would that impact premiums? And ultimately, how would the enrollment in this potential plan impact the uninsured, those that are currently uninsured? And our message from the beginning has really been about trying to expand the debate and the discussion to bring in analysis and research that looks at a wider range of stakeholders and takes into account the potential broader impacts that you might see from a policy, an unprecedented policy designed in the way in which the colored option plan is being recommended. So for this particular research and what we'll discuss today, there's really two key tools which we used, and we will have one of the main analysts that helped develop the model on the left from Guidehouse, a national, international consulting professional service group with deep expertise in healthcare, framed a model that allowed us some flexibility in being able to simulate the impact of how the change in reimbursements and the change in enrollment might impact, in this particular case, hospital revenues specifically. We then use that information to develop several scenarios in an economic model that we operate, developed by the firm Remy, to generate the macroeconomic results that, again, we'll share later today. So I'd like to pass it now to Jeff Leibach, who is the director of Guidehouse's healthcare practice. Over the last decade, Jeff's main area of expertise has been in developing and implementing managed care solutions for payers and providers, and again, led the efforts from Guidehouse's team in developing us a simulation model for this analysis.
Thanks, Chris. Thanks for the introduction. So before we dive into the levers of the model, one of the things that Chris asked that I would share with the group is kind of a recognition that the world has changed a little bit since we started this engagement. We began working with the Policy Roundtable back in January, February, thinking through this model and how we might approach it. And then obviously the world changed quite a bit with the coronavirus and COVID coming through and expanding across the country. So Chris asked that I share a little bit of what we're doing today with hospitals and health systems and thinking about the future. So I think there's two caveats. One is recognizing that the assumptions and the model itself is kind of pre-COVID, but easily adaptable to a post-COVID framework. And recognizing that hospitals and health systems are in a world of change right now. And so the way that we're thinking about that change as we work with our hospital clients in particular is that currently we're really in this first phase of responding to the crisis, helping them with urgent action response, understanding how to apply for funding, et cetera. And very quickly, we're going to be moving into kind of how do they restore their business, their regular activity, even with modifications for distancing and recognizing that we may not be out of the woods for quite some time. There's also kind of down the road a recognition that there will be a redesign and a revitalization phase related to what the healthcare industry is going to look like going forward, and how a bunch of different economic, social, and healthcare related problems are going to interact, and how health systems, payers, providers, employers will all need to respond. So just a kind of a recognition before we dive into the numbers that the world is continuing to evolve beneath our feet, and assumptions in a given model, are driven off of payer and enrollment assumptions before we had 30 million nationally folks apply for unemployment. So there's definitely a recognition of that change. Chris, anything you want to add there as we move into the model?
No, I think like you said, it's important to recognize that the current situation is very fluid. We understand here in Colorado that, and we mentioned this in our report, that as our emphasis in this modeling has to do with the financial impacts, particularly to hospitals, the information that we are gathering from the hospital systems and the Colorado Hospital Association that have been made, the announcements that have been made publicly, have articulated very severe reductions in revenue in the near term. So again, just sort of recognize that this analysis would add on top of those revenue impacts that we're seeing today. But again, very fluid situation, but I think a very important consideration in the policy discussion if this moves forward. Yeah,
great. Well, thank you. Let's go forward to the next slide, and I'll just share a little bit of how we approach the work and the model design, and then we'll get into some of the levers and the possible and the scenarios that we looked at, and then I'll share a few initial results and then hand it back to Chris for some commentary and the subsequent results and how it translated into the report. So there were really four big modeling levers that impact how we design the model and how we got to results. So the first is, what's the enrollment? What does a public option plan look like in terms of enrollment? And where does that enrollment come from? And that's the payer migration section. So how many folks are going to be in the plan, and where does that revenue come from? That all informs how hospital reimbursement changes, because we understand kind of what level will the public option be reimbursed at based on the proposal and the proposed bill, but understanding where those folks were coming from and the prevailing reimbursement rates that hospitals were receiving would help us understand what that change would be. And ultimately that translates into the impact on hospital revenues. And we took a hospital lens at this analysis largely to help understand how ultimately what hospital revenue impact would be, and then understanding that could be used for the policy roundtable as a figure that could be extrapolated into economic impact. And Chris will share a little bit more on that later on in the presentation. Next slide, please. So given the uncertainty, and this even was pre-COVID, around how many folks will enroll as a result of a public option, I think we didn't want to over-assert a level of certainty on what would happen. So we recognized that there's really a few different levers, and we wanted to look at 4 different scenarios in which this public option could roll out and how impact could be felt. So the first is, within Colorado, when the option plan is sold, where is it going to be sold? How will it be ultimately rolled out? And we wanted to model, obviously the individual market is the first large impact, and we modeled that out in every group. The second is the small group market. And this is a lever that we thought a lot about, both in the context of this analysis and a prior analysis that we did nationally, both for rural hospitals and exploring Medicare for All and public options, is to what extent any of these policies are leak proof. And by that we mean, to what extent can you say I'm targeting only the individual market when small businesses could change their offering patterns or their benefit patterns as a result of what's offered on the individual market. So we wanted to model out possible leakage or enrollment shifts from the small group market and even to some extent from the large group market. And then the following, the other lever here is whether or not Colorado uses federal waiver funds to subsidize and further reduce the plan premiums. So those sensitivities are essentially, does the plan become more competitive and more likely to move more lives based on that price differential? So we looked at a few different combinations of those options. Next slide, please. So in looking at those options, we modeled out, these are the inputs ultimately in our moderate scenario. And so, we also looked at, so we have 4 different scenarios for each different group, and then we had kind of a conservative, moderate, and aggressive version of each of them. So again, to understand fully the ranges of possible outcomes, we looked at a lot of different scenarios with Chris and the team to really understand the bulk of what could happen. So here, these are the kind of middle case assumptions here on how enrollment would shift. So recognizing that the uninsured would move, the individual market, we expect about half of the individual market to move in most of these scenarios, and a little bit more in the scenarios 3 and 4. And then a recognition in the large group and small group market that there would be a possibility of some incremental movement to the public option under, as the plan got more competitive. So, and we'll be able to size that impact later on in the presentation. So if you look at how these percentages translated into actual lives on the next page, you'll see that, we're ultimately talking about, a total lives in scenario 2, where we see the most movement between the first 2 scenarios of 245,000 lives, almost half of which come from the individual market. And then scenario 4, which is the largest shift, would be 335,000 lives. So we recognize that this is, again, the plan is intended for a large shift in the individual market and for a more competitive offering there. We think there'll be the uninsured movement, as well as some maybe unintended or additional movement that comes from small and large groups in a couple of the scenarios, and wanted to size that potential impact. So using these assumptions, we had ultimately resulted in 4 different outcomes on dollar impact to the hospital systems. And these scenario impacts ranged from 1.5% of total net revenue, or $557 million on an annual basis, to just under 4% of net revenue, or $1.2 billion. So this is kind of the range of outcomes that these scenarios created. And again, our goal as we worked with the roundtable was to try and size the potential ranges and potential outcomes based on a reasonable set of scenarios, recognizing that those could change. But ultimately, how would this impact on hospitals then translate into or be felt, first off, by this policy and potential outcomes, and then what could happen as a result? The only other thing I'll just mention before handing it back to Chris is that we recognize that we did that these impacts would not be felt uniformly by every hospital. A lot of variables go into who would experience benefits based on payer mix, service mix, and populations that you serve, and current reimbursement rates. Hospitals that receive significantly higher reimbursement rates from commercial payers stand to lose a little bit more as more people move from one plan to another. So we recognize that, and I think this is the aggregate level, but there's certainly the possibility to drill into this further by region, by facility, et cetera. So Chris, with that, I'll hand it over to you and let you continue through.
Thank you so much, Jeff. And yeah, just want to echo that last point for those listening that, are interested in this topic and want to dig further into these results, please visit our website. You can find the full analysis. We'll share the link at the end here. And we do include these impacts on by insurance rating area, by the 9 state insurance rating areas. And so you can see the relative impacts from a percentage basis and from a dollar amount. And just another way to slice these impacts, again, not directly included in the slide here, but when you look at the hospitals designated as rural versus urban, the revenue impacts to rural hospitals are more than double the impacts, again, as a percentage of total revenue than the urban hospitals. So the range there goes from about 3% revenue reduction in our moderate scenario 4 to over 6% for the rural hospitals. So again, encourage you to dig through those, and if you have any questions, be happy to follow up. But this is a high level snapshot of how the results came out on aggregate. So from that, and it's amazing, Jeff, just seeing those results here, because when you think about how detailed that model actually is, it's amazing to get it on one slide. But ultimately, the challenge then becomes for us is then taking that information and saying, okay, what does that mean on aggregate from an economic standpoint for the broader Colorado economy? And we take those revenue reductions and we've played them out in the economic model in 2 different paths. And it follows the same framework that we used again last fall, which is ultimately looking at the impacts if hospitals were to sort of internalize those cuts and face reductions in employment, in services, in capital investment that impacts the expenditures and output of hospitals in what we've termed this cut scenario, or ultimately do they pass on the losses related to the revenue reductions through increasing the existing cost shifting that occurs within the healthcare market as a second economic set of results. And I think the reality is that it would be some combination of both, and of cutting services and reducing expenditure and passing along costs where possible. So again, want to recognize that, but just wanted to again outline these 2 broad scenarios. But in the cut scenario that we ran in the model, the hospital industry, when you model out again scenario 4 moderate enrollment, so this is the public option offered in both the individual market, small group market with a federal waiver, you would see roughly a reduction in over 7% in total workforce in hospitals statewide. You can see the regional impacts across the Denver Metro, Denver South, including Arapahoe and Douglas County, and the rest of Colorado, and how that translates to total personal income reductions as well. In the past scenario, we assume that ultimately hospitals increase their prices on everyone else in order to make up for those revenue reductions in the Colorado Option Plan. And you can see how that would play out over each scenario and each enrollment assumption. Again, these are outputs directly from the Guidehouse tool. And in that moderate, excuse me, just trying to move my screens of people to get to the results. But in that scenario 4 moderate, you can see that ultimately hospitals would have to raise their prices by over 5% in that, again, moderate scenario 4 on the remaining commercial market. So that translates directly into an increase in production costs for what would ultimately the remaining commercial private insurance market would be primarily businesses. And that translates to a net impact on increasing the cost of business. I should say that in both of these scenarios, in both of these economic impact analyses, we do account for the consumer savings. So we are directly modeling an increase in ultimately disposable income through the savings that consumers are seeing through the call option plan. At the same time, we're seeing reductions in hospital revenues. And so in the past scenario, we see a statewide impact on total jobs of over roughly 7,400 jobs and total personal income reductions of over roughly $650 million. Just a note on this idea of cost shift. The bill, House Bill 1349, explicitly had included some language to allow the Division of Insurance Commissioner to have some authority to not approve insurance rates that were submitted to his office if the office suspected there was some cost shifting. Now, 2 points that we make in the report that I'd just like to briefly articulate here is, one is, the understanding is that the cost shifting generally occurs on the provider level within hospitals, and according to the state's analysis, that's where they outline the cost shifting. And secondly, Division of Insurance only regulates those that are the markets that are fully insured, not the self-funded, self-insured plans, which is over 50% of payers. And so, again, challenging to see how that mechanism in the bill would have prevented some of this cost shifting from occurring. So what I'd like to do is pass this on to Dave Davia now. Dave is the Executive Vice President and CEO of Camp C, Colorado Association of Mechanical and Plumbing Contractors. So on top of being a large part of the construction workforce here in Colorado, Dave's members also participate in an employer-sponsored health plan. And as a CSPR board member, Dave is always asking the tough questions of the research and has been very engaged and interested in the work we've been producing. So we thought it was a great opportunity to have you join Dave and share and sort of answer a more simple question than you often ask us, but ultimately, what does the Colorado Option Plan mean for your organization?
Great. Thanks, Chris. Thanks, Kristen. Appreciate having the opportunity to talk with you all a little bit and try and take what both Jeff and Chris articulated from a data perspective and bring it back home to what this is going to do to our insurance plan. So as Chris said, I'm the Executive Vice President and CEO of the Colorado Association of Mechanical and Plumbing Contractors. We're the oldest construction trade association in the state. We started in 1889 as the Denver Master Plumbers Association. We have about 160 contractor members, and we operate 4 different chapters of various national organizations, trade associations that operate in the mechanical, plumbing, and HVAC business. We're currently expanding our support and efforts into Wyoming, parts of Nebraska, and parts of South Dakota this year. We operate 5 different training centers across the state, training about 600 apprentices and offering upgrade and continuing education to several different crafts, including plumbing, pipe fitting, welding, HVAC service technicians, sprinkler fitting, pipeliners, which is your utility work. We spend about $6 million annually on training. So that gives you kind of a snapshot as to who we are. If you go to the next slide, Chris, let's talk about our fund. So construction by economy and by design is very cyclical. And so in 1955, folks who were far more strategic thinking than me sat down and said, how do we take and produce quality benefits for our participants, our employees? And then if, Dave Davia works for contractor A today and that job comes to an end and they don't have a place for me, I can go to contractor B, and as long as I transfer within my contractor members within our association, I don't have to restart eligibility again. So that really helps families, that really helps individual participants, both for health insurance and for retirement benefits. And so we offer a self-insured and self-funded plan to our participants. Just to give you a little snapshot and maybe a little bragging, in the past 8 years, we have only had to increase our premium or our revenue line by 3.14%, and we've managed our trend or our expenses at a 1.3%. Just to give you a context for that, most employers are having to see an 8 to 10% increase in expenses year over year. So I think we understand how to manage and proactively look at benefits and the types of coverage that we offer our participant and make really good decisions. And we have about $100 million in assets between the retirement funds and our health fund. Give you another little snapshot of context. When the Affordable Care Act passed, we were saddled with about $1 million in additional expenses. We had 2 different belly button taxes to pay to 2 different parts of the federal government. We had to increase coverage for dependents to 26, and we had to put something in place called stop loss insurance, which helps to ensure, since we had to get rid of the lifetime maximum insurance benefit. That stop loss insurance, when we began, was $350,000, and last year it was costing our fund $745,000. So boil this back down to the state option. You know, whenever we look at insurance, we want the best possible coverage at the least possible price for our participants. We really focus on quality of care. We focus on access to care, and we focus on cost. And those 3 things help us determine and approach expenses and making decisions and changes within our plan. So we took what Jeff and his team put together, and we have a series of consultants in our funds, one of which is an actuary with a Siegel company, and we took the data that Jeff and his team produced and ran it against our actual claims experience. And so what we're determining is about $1 million in added expenses. It's a little in excess of that. So that's about $420 per participant that we're seeing. And when we, so each employee is going to cost us to deliver the same level of care, an additional $420 per year per person. Now, the caveats I'll say to this is these expenses are focused on hospitals, as you've heard. We haven't even started to peel back the layers as it relates to surgical centers, urgent care centers, doctors, networks. And so we think that the $1 million is just a starting point. So when we get saddled with something like this as an additional expense, we have to either raise revenue to offset that. We have to reduce benefits in order to manage the cost, both of which has impacts to the participants. And so, you know, from where I sit, the state option has grave concerns to our participants. It also begins, at least to, from my chair, to impact our trend lines and our quality. So it's not inconceivable, if you look at the data that's been presented today, to start to think about if there's a greater impact to hospitals outside the Denver metro area. The question I have and the question I ask is that then going to mean we're going to have hospital networks or systems start to shutter those rural hospitals? So then what does that do to my participants that may be in Alamosa, in Grand Junction, up in Routt County, out in the Eastern Plains and Sterling? Are they going to have access to the quality of care that they're accustomed to? Are they going to have access to the best doctors to help them through whatever medical situation that they're dealing with? Or now is our fund going to be saddled with having to air life or air transport or transport those people from outside the 4 corners into the urban areas in order to deliver quality and service for whatever their care and medical needs might be? So those are some of the things that we take a look at and have concerns about. Again, this is only a start, meaning the hospitals is only part of the calculation here. there's a whole nother layer of data that we're going to have to really analyze in order to make some kind of big decisions for our members and the employees that they employ. So with that, I will stop and turn it back to you, Chris and Kristen. I'd be happy to answer any questions.
Thank you, Dave. I think that that really helps paint a real world scenario and, you know, bring all these different economic facts and figures into new light and reality for people on this webinar today. We will turn it back over to our panelists and take some questions at this point. If you do have a question, feel free to chat me. First question is related to the federal waiver. Is there a chance that the state does get a federal waiver, and they would love to understand that factor better? Chris, do you maybe want to take that one to start?
Interesting. So I guess what I can say from my perspective, and Jeff, please add in your insights, but I can't speak to the probability per se, but the latest analysis from the state following their final proposal did assume that they would receive the federal waiver. And so their latest analysis included the further premium reductions from using federal subsidies to further reduce premiums in the cloud option plan and across individual markets. So I can't speak to the probability of how that might play out and work, but I do think that that is, again, a very important piece for how this policy would unfold.
Jeff, do you have anything to add?
Sorry, I was on mute. Yeah, it wasn't something we assessed, so I think we would have to better understand what the potential implications of that waiver might be and how it would affect the assumptions.
Okay. So the next question was emailed to us. It is well known that COVID has had severe economic impact on the national and state healthcare systems. If part of the payment is to come from lower hospital charges because Colorado hospitals had such successfully profitable past years, won't the additional cost of the state option undermine the financial stability of Colorado's health system, which has been in the top 5 in the nation?
Yeah, I'll be happy to jump in here. I think hospitals are, as I mentioned earlier, I think are feeling a greater sense of uncertainty around their financial picture than in any time in recent history. I think even going back to 2008, where it was a cyclical and significant recession that had payer mix and self-pay impacts, I think that because of the uncertainty around how long actual care delivery has been suspended and what that'll look like and what capacity will look like going forward and what demand will look like going forward, just given there are so many variables. I think we're seeing in some parts of the country where hospital revenues because of shutdowns have dropped 40–50% during this time, and there hasn't been the backfill because they may not be in a COVID hotspot where they're keeping capacity available, so they're still expending costs but not getting the revenues, and then those hospitals may not be getting the same level of federal funding from the CARES Act as some of the hotspot areas. So I certainly think that this is going to be something that will continue to evolve. I think one of the big challenges is over the next 18 months, hospitals are going to be managing their balance sheets to make sure they can stay afloat, to avoid downgrades. They're going to be having to watch that very carefully, as well as their operating revenues and operating costs. And so we're already seeing hospitals furloughing employees to manage costs, driving down hourly, to manage capacity. And that doesn't even include the sense of, well, if we have this many more unemployed, what will the payer mix impact be? So hospitals certainly are heading into a different world in the next 2 years when this might go into effect. And so I certainly think that there's certainly more uncertainty and question marks around hospital finances before, that sets a new baseline that this will come into effect. Chris, I don't know if you want to add anything to the Colorado specific.
No, I think no, I think you nailed it. I think it is very uncertain. I think we were. It was important for us to model this in a way that and share these results in a way that we think does provide some ability to understand the impacts longer term in the sense that we are not explicitly commenting on how these revenue reductions ultimately impact those decisions, those budgeting decisions you made, those employment decisions you made. You mentioned the margins that these businesses would face. They undoubtedly become less, and it puts significant pressure on those margins. But these revenue numbers, I think, again, are good comparisons for whatever that new baseline becomes, because we're not commenting on again what those cost pressures might be.
Yeah.
So I think that, again, this still gives a good perspective on the revenue estimates and values, recognizing that the financial solvency and bottom line might be more dire coming out of this situation.
Great, thank you both. Next question. Have you taken a look at health sharing option?
I guess I'll just try to be brief, but no, we have not. And if there's more information on that or details or questions, I'd be happy to maybe comment, but no.
It doesn't look like we have any further questions. I want to thank you all for joining us today on our webinar and let you know of a few upcoming events that we have. Next week, we'll have another webinar on the COVID slide, which is a look into K-12 education and the impacts that COVID has had. In addition, we will have our Eggs in the Economy, which is our quarterly symposium that we host. It will be virtual in May, and we look forward to discussing items such as tax policy coming up, impacts related to COVID on Colorado's economy, and the public option. So thank you again. You can find all of the information about the upcoming events and also this full report and research on our website, www.commonsensepolicyroundtable.org. And we look forward to seeing you all at our next webinar. Thank you.